morning and welcome to Cancer Survivors Day. Thank you all for coming. We are so glad to have all of you, and I'll speak on behalf of the doctors that this is one of our favorite days because we work so hard with all of you to be survivors, and we celebrate you today and we celebrate all of your accomplishments. And so thank you for coming and spending part of your day with us. So I'm going to introduce our panelists. For some of you who may or may not know, I'm Dr. Singhal. I'm Dr. Shamli Singhal. To my left here is the other Singhal, Dr. Shiva Singhal, who's a medical oncologist. I'm a surgeon. She's a medical oncologist. And online are Dr. Sinha, who's waving to you now, and Dr. Jalili. And so the format of this is you can ask questions in the chat. I will do my best to answer them as they come up, but I have some questions for our panelists and some questions for just things that people might be really interested in. And so one of the things that always gets asked, and it gets asked to the doctors, is what is the difference between being in remission and having a recurrence? Okay, so maybe Dr. Lee, you can answer that. Oops. Yeah, can you unmute? Sorry.
Yeah. So remission generally we refer to patient we don't have a detectable disease. Can you hear me?
Yeah.
Okay, we don't have detectable disease, but there are no reach to the point we say you're cured. So, for example, we usually say 5 years if no disease recurred in early stage lung cancer, then you're cured. But if you amount the 5 years, we usually say you're in remission because you don't have a disease we can detect. Recurrence just means that the disease came back, So for stage 4, that remission and recurrence doesn't apply for stage 4. Usually refer to people who have early disease and then disease came back. That's what we call recurrence.
Okay. Any other comments from the panelists about those issues, recurrence and remission? So one of the things that we've talked about a lot is that, once there's a big transition that happens for patients, which is when you're out of active treatment and then now you're on follow-up and you're on, and there are things that you worry about, right? So what do you think is the biggest worry your patients have as they transition from active treatment to surveillance? Dr. Sinha?
We hear this all the time. I mean, when patients are going through cancer care and therapy, active therapy, they feel like they're doing something. And that's, I think it's a good feeling. Like, I'm going after this, I'm trying to get rid of this cancer, but then at some point it stops. And that's a big mental transition because you transition from I'm doing something to, oh my gosh, is this cancer going to come back? And, that's something that, is a very, but I think patients need to understand that we've things have advanced. We're in a really great shape, and we're going to keep on top of things. We're going to surveil them and do imaging and examine them. And there are other things they can do, and I think we're going to get into that, to optimize their chance that they're not going to have a recurrence.
Okay, Dr. Shiva Singhal, what do you think about this transition? What do you think are the big worries of patients?
So, as Dr. Sinha just said, when the patients are on active treatment, they feel something is being done, something is happening, but they're still worried. Will they be cured or not? Is it going to go away forever? But once the treatment is completed, and the thing you asked the first question, they are in now remission, the disease is no more detectable. That's when the anxiety part of the problem starts, and that happens, and that's very natural to know, will this ever come back? Whether you're stage 1, whether you're stage 2, or whether you're stage 4, depending on the type of the cancer, this anxiety is very normal, that will this cancer come back? And that's basically comes in the recurrence, that also comes in the realms of surveillance. But in this day and age, we have such amazing well laid out surveillance plan for all cancers, and we follow the protocol, that we are able to keep on top of things, that we are able to detect it very early if the things start coming back, whichever kind of cancer it is. So having said that, the early active treatment is like we're actively doing something, but when it comes to after active treatment is completed, we come to that next stage that is called remission, or just a follow-up stage.
Dr. Lee, what do you advise your patients to do when they have this thing called scanxiety? It's time for the scans. It's a few days before. Everybody just feels like they're going to throw up. So what do you recommend?
I told everyone that's normal. We all have that same anxiety. I think, that's why like people, they afraid of the scan, but they look forward to the scan. They say, once the scan is done, I know I have a 6 months to 12 months, I'm going to be relaxed, enjoy my life. I basically tell them, just enjoy your life as if, just enjoy your normal day life. And then the scan is just a part of the, surveillance. We'll watch it. And so I think as time move on, early on, they tend to be more anxious. I think as time go on and they see they have normal scan over and over again, that anxiety tend to calm down. Yeah.
I see. And Dr. Sinha, any words of advice for this anxiety that precedes the visit at 3 months and 6 months and 9 months?
There's not a lot you can do about it, but just like Dr. Lee said, reassuring patients that, of course, that's normal. And it's in different degrees for different people, of course. But one of the things we can do is make sure that we are seeing the patients immediately after they've had that scan. So at least that lessens the anxiety of, well, what was the result? So what we always try to do is make sure that within a day or two, the patients are seeing one of us, so they have an opportunity to, discuss the scans, look at the scans together, and I think that helps a lot. And especially now that we have this new law that releases the report to the patients directly. I mean, even sometimes before we get to see it as physicians, the patients are reading their scan reports. And as we all know as physicians, you really need to know how to interpret those reports. And even for us, sometimes we have to call the radiologist to get clarification. So I can't imagine how difficult it is now for patients when they pull up their records and they're reading their PET scan or their CT scan reports without a clear understanding of what it means. So we need to step in within a few days to help them understand it.
Right. So context of the data is really critical. And there's a lot of people here in Silicon Valley that are very detail oriented. And so I've had numerous patients that have come in and highlighted all the places in the reports where things are discrepant. And I think that, from my side as the clinician, I would tell people to work with the data be an informed consumer, you can certainly read the reports, but remember, it's in the context of your whole care, and your doctors are there to help you to understand the context. And it's good you brought that up, because it's sort of natural. The data comes in the portal as soon as it's done, and it's easy to open the portal and find out what the results are. And then there's a lot of fear that gets generated between the time you read the results and the time you see the physician. And potentially it's critically important now more than ever that we help you work with the data that's there.
To add to this, nowadays with pandemic, something new started for all of us as physicians is virtual visits and audio visits. And I really utilize my virtual and audio visits. If a scan has been done on any patient, definitely I make sure that I'm seeing that patient within 2 days of the scan. So when we send up for the scheduling, it's always that we have to see the patient with the scan results. It has become so important, as Dr. Sinha brought out, that patients are reading it and the radiologists are writing what they're writing. And then the patient is comparing it to the previous scans because they have all the reports. So it is very, very crucial that we intervene early on and we kind of explain them what it means, because sometimes what is written on PET scan doesn't really mean that it is what it is said on the scan. So comparing and helping patients understand to help their scan anxiety has become very critical in this, given that the patients now have access to their results pretty quickly.
Okay, so we have a question. And so the question is, which I think you guys are going to have a hard time answering it. The question is how often should scans be done? Dr. Sinha?
It really depends. I mean, there is no set answer to that question. And there is no set answer to that question even within a specific disease site. For instance, for certain breast cancer patients, you may be scanning them once every 6 months for the first 2 years. Other breast cancer patients don't need any scanning. And again, there are great guidelines for us to follow that have been kind of established based on data telling us how often someone needs a scan. But there is no set answer to that question. And we're going to help you with that. We're going to tell you, look, this is the risk of recurrence, in the next 2 years, in the next 5 years, and here's what we're going to do about it and in what interval.
Okay, so one of the other questions that came up, and each of you has to comment about what you think is the number one item that has come out in your field that is going to change things for everyone. Okay, and I'll start with Dr. Lee. Just one item, one thing that has happened.
I think more genetic testing, molecular analysis, and the scientific bar is going to change the practice forever. Yeah.
Yeah. So do you think that you're going to treat disease based on somebody's genetic profile rather than the type of their cancer?
Yeah. So, that's all those are reference point. Is that right? You have to combine what type of disease they have, what's the genetic background, what's their tumor's genetic background, all of them together. So I think rather than treating one disease as one name, lung cancer, breast cancer, we're going to further define them. I think hopefully in the near future, we're going to really achieve that personalized treatment, like the treatment individualized based on their own disease profile. Yeah.
So I'm going to ask you one follow-up question to what you just mentioned. Okay, so we talk about precision medicine and precision oncology. What does precision oncology mean for you?
I actually don't really have a good answer for that question. What do you think? What's your...
So precision oncology is a term that we talk about all the time, but I don't think there's a really grand definition of it, okay? So because in the old days before we had all this genetic testing, precision medicine was we were going to get this molecular profile of things, we're going to sequence things, and then we're going to treat based on that sequence. Well, we're sort of there now. So what's precision oncology now?
I don't use do you guys use that word? I usually more use like individualized treatment. Yeah. So I feel we're not really treatment based on the sequencing yet. At least we're not there yet.
I think they're calling precision medicine the same as genetic molecular marker and finding that and treating based on the genetic testing. So that is what is also individualized testing, because we are individualizing each patient based on their genetic sequencing and treating them.
But I feel like we're not there. Yeah, Bob, what you're thinking? Yeah,
so that's what they're calling it.
Yeah, I think it's an evolving area, and I would agree with both of you. I know this is not a debate, but I agree with both. We're on the cusp in the last 10 years of seeing precision medicine evolve. Now, we can do what's known as genomic sequencing of specific cancers and look for targets that we can then take action on. So that's one thing. And in my field and in Shanli's field, precision medicine has changed in that the way you do surgery is different. We now use robotics. And for radiation therapy, we now have tools and technologies that give us sub-millimeter accuracy to ablate tumors. So it's a combination of a systemic precision towards a specific target in a specific person's cancer, and a combination of specific local therapies that can now get rid of cancer in specific spots without damaging nearby tissues.
Right. So I'm just going to comment on that, and then I'm going to ask you, Bob, about the future of radiation. So in the old days, we had one medicine and 500 different kinds of cancers, and we had a lot of collateral damage to normal tissues. We've spent probably the last 20 years refining our medication to make it more specific, to make it more targeted, and so that we can decrease the amount of damage that we do to normal tissue, right? And I think that we have made substantial progress in that. And so when you talk about medication tailored to your cancer, we're talking about not giving you a broad medication that kills everything, but trying to figure out what is the medication that will suit to your cancer, right? And that's the targeting, that's the precision medicine, that's the individualized treatment, whatever you want to lump it into. But
And the perfect example, Shamli, is actually coming in breast cancer. We used to generalize and give chemotherapy just about 10 years ago. Anybody with size more than 2 centimeter, lymph node positive, got chemo. 10, 15 years ago. Then we went to the estrogen receptor status. Then now we define breast cancer is even more narrowly, and treatment is really defined. So we are coming down to more and more narrowing in terms of, as I said, cytotoxic therapy treatments or genetic treatments. So we are coming down, and that's precision medicine actually, which is getting more and more refined now.
okay, so Dr. Sinha, what is the one thing that's going to change the world in radiation oncology?
How much time do you have?
In one sentence.
One sentence. Well, I can't do it in one sentence. I'm sorry. I'll try to do it really quick. But I've been doing this for 27 years now, taking care of cancer patients. And gosh, have I seen an evolution both on the systemic side, which we were just talking about, and radiation therapy. And my job has changed. We used to do these big, broad radiation fields that would cover, the cancer, but a lot of normal tissue. But the systemic therapies have gotten so good at getting rid of microscopic disease. What my job is turning into is, well, what's left behind or what has recurred, like we were talking about. One spot's recurred. How do we get rid of it? So the short answer is it's called stereotactic ablative radiosurgery, where we can ablate cancers in the body with minimal side effects. And studies are showing us that when you do this in conjunction with targeted therapies, survival is going up tremendously in patients.
Great. Okay, Dr. Shivasingal, what's the one thing, not what Dr. Lee said? You can't overlap Dr. Lee, so you have to get.
So in oncology, the one thing that has really changed and improved survival, and is continuing to help us improve survival in many, many patients, is immunotherapy. The immunotherapy has changed the landscape, has changed the survival in many, many cancers, where we used to give our patients a prognosis of 6 months. Patients are getting cured sometimes. Patients are living longer. So I would say one thing that has changed in my experience, and which I very often use, is immunotherapy.
Okay, so I'm going to comment on surgery. I think the opportunity to do bigger and bigger cases with less invasive techniques, laparoscopy, robotics, and operating more on recurrent disease, recurrent stable disease, metastatic stable disease, all of those have changed the outlook for people. So we are repeating liver resections for metastatic disease. We're taking advantage of our ability to take care of lung metastasis and things like that with a number of different technologies. And so I think we're able to do more for patients with metastatic disease, and we're able to do big surgery with fewer postoperative complications due to less and minimally invasive surgery. So I would say about that. And so let's talk a little bit about side effects, okay? Because side effects are things that the patients have to live with after these treatments. So Dr. Sinha, can you comment on early side effects and some late side effects, things that really bother patients?
Yeah, absolutely. I mean, most of the therapies we do, surgery, systemic therapy, radiation, have early side effects. Almost all our treatments have some degree of side effects that, again, are usually something we can manage patients through. Sometimes they're mild, sometimes they're not. But to me, that's something we can get through. The big thing is the late side effects. And again, it varies from disease site, the type of therapy that's given, and so forth. And those are important things to talk to patients about up front because, for instance, for head and neck cancer and radiation therapy, I am, like I said, I've seen the evolution from where we only used to cure 50% to now where we're curing 98% of patients. However, we now have to tell patients that, look, your saliva is never going to be 100%. It's a lot better than it used to be, but you're not going to be 100%. Maybe your taste buds don't return 100%. So patients have to understand that sometimes these therapies will lead to some downstream effects that unfortunately are part of the trade-off of getting rid of the cancer. Now, as we've all been talking about, that is becoming less and less. There are less late side effects as our treatments and technologies get better. And we've all seen that.
So Dr. Lee, can you talk about toxicity to the heart for some of the drugs that you give people?
Yeah, so, there's one question come up regarding the adrenomycin. Is a very common drug we use to treat breast cancer. Definitely, there's a cardiac toxicity and even bone marrow disease we have to look out for. So I think most of the patients, when they first start the treatment, we always evaluate their baseline cardiac function, and then we evaluate through the treatment, we monitor. For people who are high risk, we usually have cardiology colleague also involved to help us manage it, to minimize the side effect. I also, I'll tell people throughout the next, usually the cardiac toxicity usually happen in the, first 5-6 years range. So they look out for, high blood pressure, any set of palpitation. And especially if they're high risk, you have a background of hypertension, diabetes, they're much more high risk for that. Of course, we try to minimize the use of this high toxicity drug as much as possible. As Dr. Shiva Shingo mentioned, we always base on the tumor, the genetic profile to try to use as minimal effective drug. And then I think my usage for this very high AC type of drug has been significantly reduced in the last 10 years. But of course, there's a effect. And then things we try to do, we gave them cardiac protection drug, like such a beta blocker to help to minimize the side effect. Yeah.
Oh, so we have.
Can I add one thing to this? I think in our El Camino we have a cardio-oncology clinic.
We do.
Yeah. So that referrals are also being sent out to help out if they do get side effect to it. Yeah.
So there's two categories of people, right? There's people who do not have cardiac disease, and then they get treated with a drug. And then there are people who come in because we have a lot of older patients. They have existing hypertension. They have existing risk factors for cardiac disease. And so those patients especially have to be watched a little bit more closely because now we're adding yet another risk factor to their profile to do that.
Yeah, definitely.
So we've, as a program, we have tried to address these. We're increasingly spending our time on late side effects of the medications that we give for a particularly good reason, because in the old days, we were just worried about whether people survived malignancy. Right now, we sort of assume that there's going to be a lot of people that survive their malignancy. And so now they're going to live on to have these side effects that we never thought about before. And so we're watching for all of those things. And it may not look like we're watching, but we're watching all the time. I would like Dr. Sinha actually to talk about this new tool that he has in radiation oncology and why it's so cool.
Sure, more than happy to. So yeah, we are, I think as you all know, we're serial number 5 in the United States for something known as online adaptive therapy. And what's different about it, and it's really, in my opinion, going to be a game changer on all these things, not just being more successful in eradicating cancers, but more importantly, reducing those late side effects that we're what it basically does is that it's a machine that can actually image the tumor and the nearby normal tissues prior to treating a patient. And if something's changed, if the tumor has gotten smaller, or let's say a loop of bowel has come in the way that particular day, it's a machine that on the fly, very quickly, within a minute or two, can replan the radiation and deliver it to today's exact anatomy. That's incredible. Normally, the computer processing and optimization time is like a week of nonstop computer work. But this machine has imaging components and incredible hardware that allows us to do this in minutes. So end result is we're gonna target the tumors better and have less side effects for patients.
Okay, and so how many patients have you treated on this machine?
Well, it's brand new, Shanley. Like I said, we're the first center, we're actually the first center west of the Mississippi to start using it. We started in April, early April. So we've had about a dozen patients who've gone through online adaptive treatment, and I've been really, really pleased so far. Not because I don't know the late side effects, but at least for short term, I can tell you the patients are doing better than what we have on our typical machines.
Right. And so are you then able to treat patients that you weren't able to treat on the previous methodology?
That will definitely be true. It has not been true yet, but I think as we gain more experience, I should be able to, feel more confident that, let's say, again, the problem with radiation therapy in terms of whether you can do it or not is what normal tissue is nearby, and am I going to do damage to that normal tissue? So just logistically, this machine is going to help us say, we're going to avoid that normal tissue, and we're going to be able to help the patient in situations where we weren't before.
No, that's great. That is really great. So I'm going to switch gears a little bit to some side effects that bother patients. Okay. So how many patients do you think are bothered by hair loss after treatment? Dr. Shiva?
I would say 100%.
Yeah. Dr. Lee, what do you think? You think that it's 100% of patients?
Yeah, I think they're definitely, bother everyone.
Yeah.
But I have to emphasize, all the hair will come back.
And what do you guys think of these tools that some centers have to help you preserve your hair, like Cool Scalp, like all the penguin things? So what do you think about that, Dr. Lee?
Yeah, I don't know other people's practice. My patient, quite a lot of them using it. Yeah.
Mm-hmm.
And then I do see it's variable, depends on their baseline hair. If they have a lot of hair, then a percentage decrease in hair, they still look very good. But if you start with a very thin hair, usually it's no that dramatic effect. And also chemotherapy based. A certain chemotherapy, I usually just tell them don't even waste the money to try it because it won't work. And some chemotherapy works better. Yeah.
Right. But you think by 6 months, everybody gets their hair back?
After the chemotherapy, I think most of people get their hair back within 2 months. You can see the hair growing back, not to the original length, but you will see some.
I see.
Yeah.
And so my experience has been is some people who have straight hair, it comes back in curly. Some people with curly hair, it comes back in straight. It definitely has a different color and texture and things like that. I would offer up a piece of advice. There are these wonderfully trained estheticians called Oncology estheticians, and they know quite a bit about all the different things that people can do for your hair with regard to helping it to grow back, wigs, prosthesis, hair extensions, all of these things. They're all out there and available. One of the things that people probably don't realize, and I'll just bring it up as things like your hair, your nails, your skin, they tend to challenge your image of yourself. And we always tell our patients to be positive. And then when you look in the mirror and you see somebody that doesn't have any eyebrows or eyelashes, it's hard to be so positive. But just understand that there's help out there, and you can talk to your doctor about it. You can talk to the nurses about it. There's lots of help available to you should you wish to do that. Another question that I have for you, what do you recommend to your patients about exercise? And I'm going to give it to you in 3 categories. During treatment, during active treatment, and after active treatment has finished. Dr. Shiva, exercise.
In terms of exercise, when you're on active treatment, it is very hard to do heavy duty exercise. You may also have a port placed in your chest wall, so weightlifting should definitely be not done, or active swimming and all may be hard while you have a port. So one has to be very careful. Some people who have been doing heavy exercises before they were diagnosed, I do advise them to be careful, especially because of the side effects of the chemo, which causes most of the times you have fatigue as a major symptom. Otherwise, most of the data on exercise and chemotherapy and exercise, and when you are active treatment, the data has shown us most of the patients should walk for at least 20 minutes. Walking is the best exercise during the active treatment. Now, after the active treatment is finished, I do advise all my patients to go into lifestyle and fitness, which is coming up as a newer way to manage yourself We have an amazing CHIP program at Camino run by Dr. Kate Collins. And I and some of our nurse practitioners are a part of it. I would say lifestyle and fitness should be involved as a part of preventing the recurrences. There is a lot of huge data, and exercise goes in a big way in putting life back into normal as close to baseline after. But once the port is out, once the fatigue has resolved after chemotherapy, people can go as close to the baseline after the treatments. But exercise should be a part of everybody's life, I would say, and in patients more so, because it definitely helps improve metabolism. It helps in general improvement of the well-being of the patients.
Okay, so there's data on yoga during treatment. So yoga during treatment has a beneficial effect, and there's data all over the place about how much yoga, and we have a yoga class usually called Laughter Yoga in the Cancer Center. Dr. Lee, what do you recommend to your patients?
I usually tell them, let your body guide you. So everyone is different. Some people exercise a lot even before the treatment, then their body probably can take more. I just tell them, exercise, try to do something every day. If your body tell you you're tired, stop, you probably can go on, keep going. So, and I don't really tell them to try to limit their exercise during the treatment. I usually say, if you can't do heavy walking, running like you do 50 minutes walk, slow walk is okay. Get out the house is very good. So I generally really highly recommend everyone doing exercise during the chemotherapy. The different form depends on their how much their body can take. And after chemotherapy, I usually say, if you know the vigorous exercise person, you do 30 minutes a day, try to do 5 times a week. Yeah.
Okay, Dr. Sinha? Any recommendations?
Yeah, so assuming, there's no risk to the bone or something else, and, assuming they don't have a port and there's some restriction on the chemotherapy side, but just talking about radiation therapy, we strongly encourage exercise because data is emerging and showing us several things. One, side effects are less when people exercise through therapy. Cure may be improved. And it all makes sense to me because when you exercise, the way I've been thinking about it is there's so many benefits to it by pumping blood, which is oxygen to the tissues, which is nutrient to the tissues. For radiation therapy, even for chemo, oxygen repairs the damage that's being done to the normal tissue. There's an immune response. There's an endorphin release that helps holistically for how patients feel. So I strongly encourage patients to try, at a minimum, try to walk 5 times a week. But patients who have a baseline of doing more, I try to keep them on where they're at and push them a little bit harder.
So we have a number of patients with the side effect of peripheral neuropathy. So peripheral neuropathy is a very challenging side effect to deal with, and particularly to tell somebody who can hardly walk because of the pins and needles in their feet to exercise. So what then? What's your recommendation on peripheral neuropathy? Dr. Lee?
Yeah, so that's also a big challenge to us too. I will have to say, we don't have a good way. I remember over 10 years ago when I was in fellowship training, we have the project, we will try to sequencing everyone's, the genomic profile to see who has more side effect, who has less. I don't think that project has gotten any positive result yet. So I think there's some not really clear data. There's some data suggests if you the cooling mint and then to keep the circulation low in the hand and feet can minimize the chemo reach to the peripheral nerve, so that may help to reduce slightly the peripheral neuropathy. Again, exercise will help. You walk and try to keep the flowing. And then also I have people doing acupuncture. I support that too. I don't see this downside. And then I want to just say also from all the studies suggest there's the vitamins doesn't really support, the high dose magnesium infusion doesn't support. So those are not positive supporting data. But on the other side, I think I have my patient doing acupuncture and to, again, and gentle exercise to improve the blood flow in that part. And then if they have some baseline already peripheral neuropathy, we try to not using the medication which can aggravate their symptom. So those people I found out, in my patient I treated, if they have a baseline peripheral neuropathy such as diabetes background, their neuropathy tend to be much more worse than the general population and last much longer.
I see. Is there anything that we can do to get ahead of it so that before they start their treatment to put them in a program, a gait training, anything like that?
Yeah, so I think early on to have them doing exercise and then again, doing the physical therapy also help too. But a lot of them are I find it very challenging. I think a lot of them are genetic related. There's no really a good medication to really minimize the effect, protect the nerve during your chemo infusion. Yeah.
Sure. So we have a number of options for alternative treatments that are good for patients. Things like massage, things like acupuncture, things like the estheticians swear on the red light therapy as a means of decreasing the amount of pain and pins and needles. So I think it's if neuropathy is going to be one of the items that we address, there's a number of different options, and each option might not work the best for each patient. And so you might have to cycle through a few of them to see if there's a good choice.
Yeah, definitely. I think a patient mentioned massage. I think all the ideas improve the blood flow. I really think that help. Yeah.
Yeah. So let's talk a little bit about mucositis. Okay, because a number of our patients get sores in their mouths, they can't eat, they can't do any of this stuff. What do you recommend them for that?
So I think mucositis, if we suspect that certain chemo is going to cause mucositis, handled early on before we start the chemo works much better than when they actually get severe mucositis. There are studies that have shown just saline water gargles done during the time of chemo they're on can prevent mucositis from happening. Like there was a study in, at Seattle at Fred Hutch, where they gave all the patients saline water gargles when they were getting melphalan during their transplant at Seattle Center. And it showed that the mucositis was less because of doing just saline water gargles during the active chemo. So saline water gargles, there is another new agent which we are using at Camino. Helios has shown us to be really beneficial, and which Dr. Sinha can actually add on more about it, because head and neck cancer patients have shown amazing benefit with Helios. So today I have started recently using Helios from our cancer center experience, and I have seen a lot of benefit. And the other thing is, when it does happen, then we have something called mouthwashes. We use that, which have nystatin and lidocaine in it, and that helps with the mucositis. And that's how but the best way to overcome mucositis is to prepare in advance. You start the early preventative treatments to prevent it from even happening.
Yeah. Thanks. Okay. Dr. Sinha, any experience with this Helios that Dr. Shiva is talking about?
I mean, I've been amazed by it. I first want to thank our, oncology nutritionist, Charis, for bringing it to our attention. And, this was maybe 2 years ago. And since we started, in fact, I saw the first patient I ever used Helios on in follow-up this past week, who was a head and neck cancer patient. Remember, these patients get radiation and chemo, and the radiation is directed to their head and neck region, to their throat. It used to be that, a third to half of these patients, we'd have to put a feeding tube in them to support them nutritionally. We have not had to do that. And not only that, I have patients now that go through the entire course of therapy saying it doesn't hurt at all to eat. And I've found the glutamine, it's just an amino acid. The glutamine that's in the Helios has pretty much been miraculous. And it's amazing because it's such a simple thing. We invest billions in drugs and radiation technology to make small advances, and then somebody comes up with glutamine, rinses.
Yeah, no, that's cool. What do you think are the worst side effects that patients go through? What do you think that is the hardest things to overcome?
In terms of when they're on active treatment, I think the worst symptom, or which we just talked about, is neuropathy, which is so hard to treat. And so many of our chemo drugs can cause neuropathy. I think that is very hard for most of our patients to go through or find treatments. And sometimes it is so resistant that we don't have treatment for those resistant and the persistent neuropathy. So it does affect and disable their life going forward also. That is the main. The other is psychological. I think the other main thing that patient goes through is fatigue. The chemo fatigue and a forgetfulness that comes sometimes after chemo is also very real. So chemo fatigue and neuropathy.
Sorry, I'm trying to address some of the questions that people have posted with a type, but I don't have a keyboard. So I'll get a keyboard and then I'll answer some of them. We have some complex questions in the chat, which are hard to answer because they're sort of one related. But I'm going to give Dr. Sinha the opportunity to comment on some features between so one of the questions that came up is, why is surgery recommended for prostate cancer versus proton beams or seeds? Now that is a whole topic.
I was just typing the answer privately back to the patient, to the person who had typed it. So I'll just answer it publicly here. So treatment of prostate cancer is very confusing. There are a lot of options. I think the question that I saw was, why remove the whole gland or treat the whole gland when, sometimes you can just treat and identify the cancer. That's called focal therapy. And we are now in an era where our imaging tools with MRI and what's called PSMA PET scans help us identify early cancers in the prostate. And there is emerging evidence that in certain patients, you can just focally treat that area and not treat the whole gland, not remove the whole gland, not treat the whole gland with radiation. But that's an evolving area, and it's a case-by-case basis. I've done it, and it works. But again, you have to be very selective in who you choose. There are other patients with prostate cancer that the risk is higher, that the cancer is not just in that spot, that it might be outside the gland or perhaps even in the lymph nodes. It doesn't make sense to do focal therapy in that case. So bottom line is, if there's a question about prostate cancer, you need to get an opinion or multiple opinions from doctors who have all the tools available to them.
Right. And so so I'm just answering a couple of the other questions. One of them has to do with, can you join the CHIP program if you're part of Stanford Healthcare? Yes, you can. We can certainly provide you with information about how to join that CHIP program. And in terms of going forward, we're really about cancer survivorship now, right? And we're trying to work with patients so that once their cancer has been actively treated in the surveillance portion of it, how do you envision patients going forward from this cancer diagnosis? What do you recommend to them? So we've talked a little bit about exercise. We're going to talk a little bit later about nutrition. Now we're going to talk a little bit more about the attitude, right? How do you cope with the remission attitude versus the survivorship attitude versus the active treatment?
So the survivorship is you have been cured of cancer, 5 years are out. By definition, after the diagnosis of cancer, you are in remission. And most of the cancers, I'm not talking about stage 4 metastatic cancer, but early up to stage 3, most cancers, you are called cured, and that begins your survivorship after that. In that setting, when you are a survivor, you always have this anxiety. So we have to deal with that anxiety. And for that, you need a social component, and you need a lot of support system. Lifestyle, as I had said before, that plays a big role. And then, as you said, nutrition plays a big role. So I think from there on, our goal should be to put our body in such a way that we work towards preventing recurrence, and we work towards eating right, exercising, and working towards making it as healthy as possible after all the treatments you have had and the side effects you have dealt with. So 5 years after, one needs to now feel, okay, my cancer is gone. Now this is done. This is a part of my life. It's gone behind. Now I need to take foot forward and not have the biggest component that one has to deal with is anxiety. Will this ever come back? And I would say, and I tell this to all my patients, leave your anxiety to us. That you need to be totally stress-free, totally mentally free, that in this day and age, we have tools. we will be able to find if it happens. Just leave that stress to us and live a stress-free life. So I think that's how I would put it, and have them go to the programs, understand what is the way to eat well, which we're going to talk, as you said, in coming forward, and then exercise, find a ways that you can, put things together and live a healthy and active life.
Dr. Lee, any other advice for the patients?
Yeah, I think that all good advice. I think try to live a normal life is most important, So when I said normal life, exercise and eating healthy, but you don't have to straight follow up certain diet. I don't agree. I don't believe there's one diet, you have to totally eliminate red meat, or totally eliminate sugar. I don't think that's the right way. But I think try to live a normal life, enjoy the life, and then exercise, keep healthy, don't gain weight. Of course, like we always said, follow up with all the other health prevention program. For the anxiety, we do have a very good psychologist in our program. I think everyone who has anxiety, I really highly recommend them to connect with someone to help them go through. I think that anxiety will fade down, will gradually disappearing the longer you're in remission. Yeah, it's a very normal part of the process of fighting the cancer. Yeah.
So we have studiously avoided the topic of this year in the world of COVID and cancer. So I'm going to bring it up because hopefully we will put this behind us as a topic. How has the COVID quarantines and all of these things, what are the questions that patients ask you about that? Dr. Sinha, anybody ask you about vaccines, about quarantines, about getting different medications, anything?
Yeah, radiation therapy, it's actually a really important question. Like we went through, obviously, our first phase of fear with COVID, and, the patients needed to come in for their treatments, whether it was chemo, radiation, or surgery, and, our job was to protect them. So that was the first phase, and that's what we were dealing with patient questions. How are we going to protect them? What are we going to do? I mean, what we did in radiation therapy, which I think most places did, was no family members, unless absolutely necessary, were coming in with the patient, one patient at a time in the department. I mean, all the necessary precautions with masks and face shields for our staff and the patients, temperature checks, so on and so forth. But then it transitioned into the vaccine part, while patients were on treatment. Well, what's going to happen to me if I get my vaccine while I'm going through radiation therapy? And that was really an interesting phase for me, because radiation, activates the immune system. It's an immunogenic therapy. That's one of the ways it helps kill cancer. And what we saw, actually two things I saw. One was that this is anecdotally, but patients who got their vaccine while they're on radiation therapy, they had more vaccine side effects. So as I saw the first couple get their vaccine and see even after the first dose, they were having side effects, I kind of warned people, hey, we've got to keep going. You may have more days and more severe side effects with your vaccine, but do it. It's really critical. And the other thing that happened that was really interesting, I started getting phone calls from certain patients that we had treated a while back that, wait a minute, my symptoms are getting worse. They're coming back. That things that I had on radiation therapy are now returning. And it was timing-wise, was right after their second COVID shot. So I found that very intriguing. And it's, one of those things, you don't know what you don't know until it happens. But, overall, there was no major harmful effects, just some transient effects that occurred during radiation.
Okay, Dr. Lee.
I personally have not seen too many major side effects for the patient ongoing for chemotherapy. Of course, certain treatment people may not mount good response. So there's a recently data published in the Nature Medicine, I think, talk about people with a blood-related disease. They tend to not mount in good response, and then people talking about third boost, but those have not been really approved by FDA or shows any evidence to do that. But I like Dr. Sinha, highly recommend everyone to get the vaccine. And I personally have not seen significant side effect to interfere with their treatment or make their disease worse. So I think it's good we all get protected. And then in our cancer center, I agree. So at the beginning, people couldn't come, even when they come by themselves, lots of information can get missed, and we always have their partner on the call, on the video. So now I think things change a lot, and I appreciate our nurses have done amazing job of keep everyone safe. Yeah, I think the cancer center has been a very safe place. We never closed one day due to the COVID. Everyone get their treatment on time. Yeah, so I think lots of staff to their hard work really help our patient to go through the difficult time. Yeah.
Right. And on the surgical side, I would say that people did not really go for their screening treatments. So they didn't go for the mammograms, they didn't go for their colonoscopies, they didn't follow up with regular primary care during the last year and a half. And a lot of patients are coming in with kind of late stage disease to the clinics because nobody wanted to come in for one thing or the other. And it's true on the side of cancer, and it's true on the side of appendicitis. People are coming in with perforated appendicitis where we never used to see that before because people didn't want to come to the hospital, people didn't want this or that. And so I would encourage people to look back and see if you've missed one of your appointments for your screening tests. Make sure that you've taken care of your cholesterol. Make sure that you've done what you needed to do so that you can stay on that healthy track. That would be my concern about our COVID experience here at the Cancer Center. And as we're starting to come out of restrictions and things like that, the clinics are busier and people are harder to get a hold of because there's so many more patients coming back into the system. So that's one of them. And then we have about 6 or 7 minutes, and we have a number of very specific questions. And so if the doctors could look, if the doctors could look at the questions, and if there's anything that they should answer offline, that's cool. I think that would be great. And any last discussion about wellness for cancer patients, about what going forward do you think has worked for people? Like how does it, if someone was sitting in front of you and saying, listen, you know what, I'm looking at the next 5 years, how do I adjust to the diagnosis that I have? And what specific things, not the general things that we've been talking about exercise or nutrition, but are there any specific items that you think really are good for patients that we have not talked about? Anybody? Yeah?
Silence, I think, means we've probably covered it in general ways. And again, I think it's really dependent on the patient, and that's what we try to individualize. I don't have anything specific besides the 4 pillars we've talked about, which, to me are the mental health and support systems, the nutrition, the exercise, and the ongoing medical care and support. So, again, that's all individual for each patient, kind of tailoring that properly.
So I have had the experience where a patient has come and there's a number of things that they just don't want to talk to the doctor about, right? So they're bothered that their nails are cracked. They're bothered that their skin is too dry. They're really bothered by the fact that they don't have any hair or eyelashes or eyebrows or things like that. But patients don't necessarily bring it up to the physician. And I had an experience a number of years ago where a woman who doesn't necessarily look like a fashionista. I mean, she's sort of a t-shirt and jeans sort of person. And she had come back for a recurrence. And she had breast cancer 20-something years ago. And when she came back, she said, I don't wear certain clothes. I don't go out of the house. I feel like my original surgery that I had 25 years ago was really, I was maimed by that surgery. And so I stay in my house mostly. I don't do this, I don't do that, and I don't do the other things. And so I guess my only addition to what we've been talking about on these pillars are, if there are things that bother you, that one should surface them to the doctor, to the nurses, to somebody, because holding all that in makes it very difficult for us to help with any of those items. And this issue, and particularly for a lot of the breast patients, is that there's a body image issue that prevents people from feeling really that they can go forward, or any of these things that can be talked with our psychologists, with our nurses. We have solutions for things. And so I don't think it's necessary for people to feel that treatment has somehow changed them in ways that they can't recover from. And I don't know, obviously we can't address things we don't know. So if these things come to our attention, we're happy to address them and just understand that there are solutions for a lot of it. And on that note, I think we will answer any of the questions, new questions that have come up, and I will give the doctors a minute to answer some of these detailed questions that people have asked on the chat. Okay, so we can break for intermission, right, Brian? We're
at 10. Yeah, we have about 3 minutes.
Yeah, so I'm going to give the doctors 3 minutes to answer these 5 questions that are here, which are quite hard. So I'm going to read them out loud, but probably the answer will come as text or chat, whichever one of you decides to take. For the online adaptive treatment for patients finishing chemo and have the need to do radiation treatments, does it replace the broad beam standard approach for breast cancer?
So for breast cancer specifically, we are not using online adaptive, primarily because there are other technologies that we use that we target the whole breast when we need to and can spare the critical structures really reliably. And now there are certain categories of patients that really don't need their whole breast treated. Again, it depends on the cancer parameters and the pathology, but we do what's known as partial, which is accomplished in 1 week to just part of the breast, not the whole breast. But no, online adaptive is not currently needed for breast cancer, is the way I would put it.
So this one's a hard one. What can I be doing as a patient to optimize my chances of survival, both during active treatment and post-treatment? In other words, who is your ideal patient and their behavior? Ideal patients?
So ideal patients and their behavior is based on our huge data, which we have been doing this for now years, is when you're on active treatment, just follow the protocol. The treatment are designed based on your cancer, based on evidence-based medicine. And we have a whole team of cancer support system at Cancer Center. Utilize that to your benefit. When you're on active treatment, don't try to eat healthy, don't try to lose weight, don't try to work towards working on nutrition and exercise as a part of preventing cancer. At that time, your goal should be to go through the chemo and radiation, which is a part of your treatment and surgery, which 3 makes up the full treatment protocol for most of the cancer patients. So an ideal patient would be who follows those 3 protocols, accepts, okay, I got this cancer, now I need to conquer this, right? So we do this. During that time, we eat whatever, because we don't think about, okay, glucose is, I don't want to eat cheesecake, I don't want to eat this because that's feeding my cancer. Those kind of thoughts should be just kept out. We should just focus on cancer, get ourselves cancer free. Then comes the next behavioral, then you are in remission. During that time, you start working on, as your fatigue gets better, as you improve towards the side effects of chemo gets better with time, then you take on, okay, whatever is possible in your control, start working on getting to the normal baseline with diet, exercise, nutrition, and mental health. Working on all 4 aspects and then going from there. Utilizing, as Dr. Sinha had put on the 4 pillars, using all the pillars and using medical system, which is against very evidence-based. We have National Cancer Care Guidelines. We have American Society of Clinical Oncology Guidelines, which are used for following all patients during their remission and after remission. When you are cured of cancer, there is a way to follow each of you. So and just follow that, because it is big. This is all based on studies. Things are varying, but that would be an ideal patient and ideal follow-up.
Yeah. Jelly, any other thoughts to add?
Yeah, I think everyone is different. We all have our own way to cope with the side effect, so how to deal with the difficulty in life. I think I don't have a prototype of an ideal patient. I think as long as you do all the treatment you're supposed to do, and then we try to minimize the side effect based on your lifestyle and how you deal with them. I think, just general thing, take all the treatment as, as the standard recommendation. After treatment, I do recommend living a healthy lifestyle, so exercise, keep the certain weight, follow up all the routine follow-up as blood pressure, cholesterol, diabetes, all this, do your follow-up. So I don't really have a true ideal patient type. I think everyone is very different how you deal with, the stress in life. Yeah.
Dr. Sinha, ideal patients?
To me, it's a partnership, a very important partnership, because we're talking about someone's life where we are engaged with them and their family. So understanding, their philosophies, their abilities to do various things. But I always, I segment it into those 4 categories in my mind when I meet someone. The psychosocial and the support aspect, the nutrition aspect, and the exercise. And then, of course, the big part when we're on active therapy is the treatment aspect. And, going through the therapy in a multidisciplinary way and in partnership with them. So the ideal patient is somebody who's, mentally on board with all 4 pillars, saying, hey, yeah, I'm going to do everything. Everything I need to do to beat this cancer and everything I need to do to minimize the side effects. And sometimes the patients even have ideas that, they've researched and come up with that I learn from. And like I said, it's a partnership where we work together through it.
So I'm just going to add one last comment, and it has a lot for me to do with we value the team, and and the team includes the patient, their family, the providers, the all this, the ancillary staff that surrounds this patient as family, right? We now, once you have this diagnosis, we're all part of this team that takes care of you. And so that the ideal patient for me is willing to engage with all the team members, is willing to accept the contributions of all the people on the team. So I, the physician, am with you for the hardest moment of your life. It's your diagnosis, it's the first elements of treatment, it's the seeing you every year. And I enjoy seeing you when you come back for follow-up and seeing that things are working for you, that you're gone back to, the Kentucky Fried Chicken that you loved once in a while, right? I appreciate seeing all of that. And when you come and your openness to the team, right? Because the team is going to take care of you in all different aspects of your care. And for me, it doesn't matter whether you have this opinion or that opinion, or whether you choose to do one thing or the other, but just the openness to having the team work with you, I think is probably the biggest part of my sense of ideal patient. Although I don't really categorize people into ideal and not ideal. And let me take the last question, and then we'll break for intermission. So meditation and prayer has helped tremendously in enabling me to navigate and have to live with cancer hovering over me. I think it's critical for patients to be able to calm their anxieties. Is that part of ECH's program? So we have support groups. We have, I don't know that we have a specific meditation group, but we have support groups. We have laughter yoga, which incorporates a lot of meditation type tools. We have different activities for patients, because support comes in different ways. It could be that you have your gardening group, it could be you have your paper folding group, it could be that you have the support group. So we've tried to work with how people would like to be supported and go from there. So I really appreciate all of you spending your Saturday morning with us. We're going to take a short intermission, and then we're going to get to Charis, who is going to tell us all the secrets of plant-based nutrition in about 15 minutes. So we're going to take a short break. I thank you, doctors, for taking time out of your day to spend with our patients, and we will see you another day.
Thank you.
Thank you.
Thank you.
Okay. Welcome back. I hope you had a good intermission. We enjoyed our first session, and now we're looking forward to listening to Charis speak about nutrition. Charis has been our oncology dietitian for a number of years. I've known her for many more than that. She used to be an inpatient dietitian when I first met her, and she has probably the best attended session of every Cancer Survivorship Day that we've ever had. People have lots and lots of questions and lots of interest about what to eat and what's actually recommended to eat and what's the data for it. And so I'd like to introduce Charis to you. If you have not met Charis, this will be one of the most valuable sessions you have ever had. Okay, Charis, we'll unmute your mic and we'll get started.
My background was set by my husband for something else, so it's not.
Well, that's okay. We will really appreciate all the comments that you have to make today, and I'm sure that there will be lots and lots of questions. So just save a little bit of time at the end to answer all the questions that will come up. Okay, go ahead, Charis.
Just one moment, please.
Okay. Shiva, can you answer any of these questions?
Yeah. Okay, I'm going to share my screen so I can get out of these blue flowers.
Just say thank you.
All right, well, for one thing, thank you. Oops, golly. Okay, sorry about that. For one, thanks for all coming. I love Survivor Days. I like to pick a hot topic usually, something that will really spark people's interest. And, you know, I think nutrition comes into play because it's something that you can do. It's something that people are always investigating. You know, your treatments are decided, of course, in tandem with your physicians and so forth. But what I'd like to do today is talk about plant-based eating, the what, the why, and the how. You know, and there's so many proposed ways to do this. And at the same time, people want to be satisfied after a meal. You don't want to be playing all these mind games. You really want to enjoy your food. And so it's like, where do we go and what do we do from here? I'm sorry about this. I am not used to. Okay, so plant-based eating, what is it? These are what we're going to cover today. Why would I be interested? And how would I eat this way? So what we're going to do is describe a plant-based eating, because there are lots of different ways that people think of this. And you have to really have a driving reason why you want to be looking at your nutrition. So what does plant-based eating offer? And the most important part is I want to leave you with some things of how do you do this? You know, what are some takeaways? Because we can talk about how we want to do things all the time, but it's really when the rubber meets the road and when you get home and when it's time to eat, what do you do? So I have to, I love these pictures when I'm picking them out, because a lot of us, you know, plant-based eating, we think of vegetables, and as kids, or if you're a parent and you've had kids, it's like, it's not people's favorite thing often, or maybe you've been told by your parents, eat your vegetables and then you can have dessert. So it's not your go-to food, you know, and yet maybe during COVID, you've watched a lot of the documentaries. There has been like Game Changers or Fat, Sick and Nearly Dead, or Forks Over Knives, which really brings the plants into focus and what health benefits they have. Now, those documentaries may be a little extreme, but they really do show us that what you eat can make a difference. So here we have, you know, someone who's, you know, looked at some of those documentaries and is ready to tackle a plant-based diet, which is pretty fun. Hopefully you do that. So what does a plant-based diet look like? There's not one definition of a plant-based diet, and this kind of shows the spectrum. A lot of people will immediately think that a plant-based diet means you have to go totally vegan. Some people may be vegan for cultural reasons or philosophical farmer reasons, but a plant-based diet is really what I would say is a plant-forward diet. So instead of thinking I'm having chicken for dinner, you might be, you know, have gone to the market produce market or a farmer's market and you found, a big, nice bunch of spinach, maybe you got a eggplant, maybe you got a butternut squash, your meal will be planned around that instead of I'm having chicken, I'm having fish. It's the idea, that's the first thing that comes to mind. So here we see from the bottom of the screen, we have the vegan, which is eliminating all animal products, up to the top, which is kind of more your Mediterranean, where meat is used more as a condiment. And when I use the term meat throughout this presentation, I'm going to be talking about animal products like poultry, fish, beef, lamb, pork. So a Mediterranean diet will have less of that and it might be kind of sprinkled in. And again, it goes through, maybe someone's cut out the red meat and beef, lamb and pork and is just eating seafood, or maybe they've cut out and just have dairy and eggs. So it can be a variety of these. All of these are plant-based diets and they all have some benefit. So the goal is a predominantly plant-based diet, whichever version. All of these are limiting things that you may have, the terms cholesterol, saturated fat. And so all of these is a good advice. Now, the interesting thing is you can be 100% vegan, but that may not necessarily translate into always healthy food. Here, this picture shows chips and, maybe a gelato or a sorbet and cookies, but that doesn't mean those are all healthy. So terms have to be looked at a little bit more closely. And I like to bring this up as an example. Here's some labels. One is from a very popular vegan burger, and one is just ground beef. And so if you look at here, we have calories per 4-ounce serving is 240 in this vegan item. And here the calories are 150 in a 4-ounce serving. Okay, so one's less calories. Then if you look at fat, we have total fat in the vegan is 14, total fat in a lean beef is 5, saturated fat is 2, saturated fat over here is 8. Protein is both decent, but then you take a look at the ingredient list. So what we're talking about when we're a plant-based diet is looking more at the whole food as natural as it can be, because when they start adding all of these long list of ingredients, some of them might be vitamins and minerals or enrichment, but let's stick to really the whole food diet. So it's kind of described briefly. We don't have a lot of time, so I'm going to hit the high points here. Is why do I eat a plant-based diet? You really want to determine your goal in this, because this is what's going to sustain your desire to continue on changing your lifestyle. So a plant-based diet, how does it help? It helps you eat healthier. It may be because you want to do this because it prevents disease. And I will say that, and we're going to talk about how it does it in a minute, but a plant-based diet helps with a lot of chronic inflammation in the body. So you're looking at diabetes, hypertension, cardiovascular disease, glucose intolerance or prediabetes. So a plant-based diet can better manage and reverse disease, and it can boost your energy. You can have better weight management, and actually it can be pretty cheap. So I'm going to let you take a minute right now, actually, and think about why is it that you would be interested in a plant-based diet? And then we'll look at what is it about plant-based diet more specifically? And this is a colorful picture, and if you ever have gone into a farmer's market, they're beautiful. That you look at how they've piled up all the produce, and the colors are amazing. And those colors distinguish different phytonutrients, and they're in groups. And so I have people that come a lot of times and say it's blueberries. I've got to eat blueberries at breakfast, lunch, and dinner. They have resveratrol, and they're going to really help me fight my cancer and my inflammation. But there's not just a single phytonutrient. The different groups of colors are stronger in one phytonutrient, but still within like one apple, there may be up to 1,000 phytonutrients. So the goal is, maybe you don't like broccoli, but maybe there's something else in the green group you like, is to eat a variety of foods. There's not one food that cures cancer. There's not one food that causes cancer. And this is a good example of the phytonutrients. So I have blueberry and spinach up here. And this also demonstrates why eating the food is better than taking supplements. Because you can sit and you can buy Resveratrol, you can buy different like turmeric, but if you eat the food, you can see that it has vitamins and minerals, and the phytonutrients are things that actually plants have within them that help them fight disease. And when you eat them, they can prevent DNA damage, reduce inflammation, help with DNA repair, can sometimes slow the growth rate of bad cells and help the bad cells kind of die off sooner. So that's what we mean by phytonutrients. They not only help us fight cancer, but again, they help us fight some other chronic diseases. So you can see why it's important to eat the whole food, because they work together, each of these components, versus lining up your supplements and spending a lot of money on the supplements. Each one has a different action. I bring this slide up is because I hear a lot from cancer patients that they're very afraid of carbohydrates or sugar. And so, yes, they may say vegetables are fine, but they're afraid of fruit because isn't fruit too sweet? Isn't fruit full of sugar? And definitely carbs get a bad name across the board, not just with cancer, but with weight and so forth. But I want to just remind you that in whole grains are a plant-based food, and they have phytonutrients as well. And it's more than just fiber. You have, these are the phytonutrients, the lignans, and they have some phytoestrogens, which I'll get to in a minute as well. But they're rich in minerals, and so it's not a bad thing. So no carb fear here. Don't forget that in whole grains there are phytonutrients, and they deserve a lot more nutrition credit than they get, because they in fact have cancer fighting properties. So I've talked about plant foods for the fight against diabetes, hypertension, cardiovascular disease. But since this is Cancer Survivor Day, I do want to look, at plant foods and how you work that into your diet as a cancer survivor. And how does the average American compare with their vegetable intake? And what's interesting is that men and women eat only an average of 1.5 cups of fruits and vegetables total a day. And really, the goal is at least 2.5. And for cancer survivors, we actually want to get up to 8 servings a day. So what's a serving? A serving is like a fist size. So that might seem impossible. But if you think about having a piece of fruit at breakfast, lunch, and dinner, if you don't have the fruit at a meal, you could have it as a snack. And having a fistful of vegetables at lunch and dinner, that gets you almost up to the 8. So all of our effort and thoughts about eating healthy is, I really regret eating healthy today, said no one ever. But I want to translate the thinking about eating healthy into actually doing it. So your decision, your efforts will not be in vain. You can take a step, and I want you to notice it's a step. It's not, I'm going to do it all tomorrow. Just like when you start exercise. I remember when I was a runner for many years, but when I started running, I ran halfway across a track and I started crying, and in a year I was running long distance. So, it can be the same thing when you're eating or trying to change your diet. It's going to take maybe some effort at first until it becomes part of your everyday lifestyle. So don't get discouraged, because your efforts are not in vain and you're not going to regret it. The other thing is that maybe sometimes you can think about, I've gone to a party and I ate a lot of this food that I normally don't eat on a daily basis. And you come home and you're going, I just don't feel right. So I think eating right has a benefit to you that day. It's not always like, well, if I eat right, my cholesterol will be really good, when I get it checked in a year. No, it makes a difference for how you feel that day, both mentally and physically. So how and where do I start? So I want you to visualize what your current eating looks like. Now, to do that, it's really hard. I often ask people, well, what'd you have to eat yesterday? And they can't even remember what they ate. So, it's best to maybe write down what you eat. And this is really for your own eyes, not for anybody else's, although I'm willing to meet with you too. But when you actually write something down, that's when you can start looking at, wow, I didn't realize, I didn't even eat a piece of fruit yesterday. Or wow, I missed a meal. Or maybe I didn't plan something and I went and grabbed something. But it gives you a good idea to look at your current habits and identify areas for realistic change. And don't think about it as a diet, but as a lifestyle change, because we want to always do this major overhaul. And that's when we become overwhelmed, we become frustrated, it's unrealistic, and we need a few places to start and then add from there. One of the things you might want to do is think about what plant-based meals are you already eating. So here's a picture of a burrito and some pasta. So burritos traditionally might have, chicken or beef. You can sometimes get just rice and beans. So obviously the rice and beans is going to be a plant-based burrito, but maybe packing that burrito with extra vegetables. I like to do the trick. How can you add a vegetable to what you're already eating? Why don't you saute some zucchini and put it in that burrito? Or maybe even some sweet potatoes, roasted sweet potatoes, black beans, and white and brown rice in a whole grain burrito. Top it with those salad fixings. On the other side of the screen is pasta Primavera. And that's really just, here it's showing a whole grain pasta with lots of vegetables. And it's a great way to use whatever's in your refrigerator. You might want to add a can of cannellini beans. So that's some very simple plant-based meals that, could frequent your weekly meal pattern. So meal transformation, it's not about reaching perfection. Progress is your aim. This is a picture of kind of a new American plate, you might say, a cancer healthy eating, a plant-based eating, and it's half your plates are non-starchy vegetables. I want to define what a starchy vegetable is. A starchy vegetable would be like potatoes, winter squash, peas, corn. So basically anything else is your non-starchy vegetable. And it's half your plate or a full hand from fingertip to here. Protein is going to be a quarter of your plate. And here they're showing some plant-based protein. And another quarter of your plate is a whole grain. Now, obviously, it doesn't have to be separated unless you have kids that don't want to mix their food together. It might be a mixed dish, but again, it's going to be showing that the majority of your plate is vegetables. Then at the bottom, it shows what you might want to do during the day is somewhere add a piece of fruit, add a salad, add an ounce of nuts. And an ounce of nuts is what fits in the cupped part of your hand. And nuts are, it's a protein source and they're healthy fats. And they actually have been shown to even help reduce weight because they're really satisfying as a snack. So meal transformation, that's kind of what the meal looks like. But we want to plan out your protein. We want to reduce refined carbohydrates. We want to use plenty of non-starchy vegetables and look at using some healthy plant fats. So again, this doesn't mean you can never use some animal protein, but since that's an easier thing for most of us to do, I want to talk about some of the alternate plant-based proteins. So there are beans and legumes. And so we think about kidney beans, black beans. There's lots of different colors of lentils. There's cannellini beans. There's pinto beans, lots of them. And then we have nuts and seeds. And it's amazing what you can do with nuts and seeds. You can make cashew cream, or you can use tahini for sauces. And then soybeans. I want to spend some time on soy because people also have some soy fear. Soy's phytonutrient is phytoestrogen. So if you have a hormone-sensitive cancer, people are afraid to eat soy products. So that it's the name of phytoestrogen that is fearful for people. But studies have shown that in cultures where soy products are part of everyday diet, that hormone-related cancers like breast cancer and some of your gynecological cancers are lower. And people in those cultures are eating whole soy foods. They're not eating soy powder proteins or the filtered soybeans. They're eating the tofu, the edamame, the soy milk, and so forth. So the studies have shown, and this is internationally and nationally, that you can have safely up to, if you want to be moderate, it would be 3 servings a day of 7 grams of protein. So that means you could have a half a cup of tofu, you could have 1 cup of soy milk, you could have a half a cup of edamame, and that's totally fine. Doesn't mean you have to eat soybeans soy products if you really don't want to, but for people who that's part of their everyday diet, there's no reason to be fearful of soy. The second part of planning a meal transformation is reducing refined carbs. So you want to be choosing whole grains. It doesn't mean you have to choose whole grains all the time. If you were choosing them 50% of the time, that would be great. So what are whole grains? A whole grain is a grain where it has the outer part, which is the shell, the endosperm, and the germ, where something like white rice and white pasta, they've taken out the outer shell and the germ, and then they've added back nutrients, but that doesn't have the fiber, and it's taken away some of the phytonutrients. So whole grains would be things like, your brown rice, your whole wheat pasta. There's a lot of grains. There's, there's the quinoa, the freekeh, the farro, the barley. And I like to suggest to people that when they go to the store, they go to the grain section. On each shopping trip, you might want to get 1 new grain that you've never tried before. And if you have a rice cooker, you can cook it just like rice, but otherwise it says right on the package how to do it, and just kind of start building your pantry. The second thing on meal transformation is including vegetables. And, if you're someone who lives alone, or you're worried about vegetables turning to mold in the refrigerator, there's not a problem with buying frozen vegetables. Get the frozen vegetables without the sauces. You can pour out what you need. You can either stir fry it or microwave it. Otherwise, so it's not like less healthy to eat the frozen vegetables. And also, you do not have to buy organic vegetables. That's your choice. Phytoestrogens might be a little higher in organic vegetables over non-organic, but the main thing is that you wash all of your produce well with water, with friction. You don't need a vegetable wash. So it's more important that you eat more vegetables than you worry about the risk of not eating organic vegetables. If you were interested in really the pesticide component of your vegetables and fruit, you can go to Safe Fruits and Vegetables, and you will find that you have to eat like this enormous amount of like apples in order to get up to a pesticide level. That's a problem. But that's, again, an individual choice. And then work in whole fruit. I put whole fruit there because a lot of us have a tendency to just drink the juices, and that's a lot of calories for one, where body weight is important, and it doesn't give you the fiber. It doesn't give you the feeling of fullness or satisfaction, from eating, and it can lead to tendency to weight gain. Fruit juices also, because they don't have the fiber. If you have insulin resistance or glucose intolerance, it can really shoot up your blood sugars. So kind of the key is when you sit down to your meal, I like to say, play this game. Sit down to your meal and look at what it is. How can you add a vegetable to that meal? I used to work with a woman who had 3 sons, and she would make them, the peanut butter and jelly sandwiches for lunch, for school, and she'd throw in some spinach leaves. Now, I'm not saying you have to do that. That was kind of a crazy way to add some greens to a meal. But again, it might be grating a carrot into your pasta sauce. You can't even see it. For people who don't like vegetables, you want to hide more in. It's just, you can just think about how you add a vegetable to what you're eating. And I focus on this because it's a little easier to get fruit in, and vegetables, we just, all of a sudden it's the end of the day and it's like, wow, I haven't had any. Where is it? Or get in the habit of always having a salad. And at the stores now, it's so easy to buy pre-cut vegetables, pre-washed greens. So the convenience aspect of that and the time saving is taken care of for us. The other part of healthy eating is the different types of oils and fats that we use. I want to say that all fats and oils are equal in calories. So part of eating healthy is being at a healthy body weight. It doesn't mean you have to get to an ideal body weight. Often losing just 5% of your weight will change your metabolic profile, your lipid panels, your glucose, your high blood pressure, your risk for cancer even. But we talk about healthy fats are those that are more anti-inflammatory, and that's the body inflammation that can, again, lead to more chronic disease. So what are those fats and oils to use? Olive oil, algae oil, canola oil are all more anti-inflammatory oils. Nuts and seeds are healthy for you. And it's so easy to just use too much of this. So again, I like to use your hand as an example. It's your thumb. You know, if you're having some salad dressing or pouring some oil on your, vegetables, a thumb is about a tablespoon. So kind of watching your portion sizes for that. Now, on the other hand, when I'm talking about all of this plant-based eating, this is for someone who is not dealing with a lot of side effects from cancer. Because when you're in the midst of like heavy treatment, IV chemotherapy and so forth, sometimes you can't have a lot of vegetables because you're having a lot of gastrointestinal symptoms, or maybe you're having diarrhea. And vegetables also fill you up. And so you're not getting the calories you need to keep your weight on. So I like to coin the term, do what's healthy for you today. It doesn't mean you'd never eat vegetables, or you never do this, but sometimes when that's going to be a smaller part of your plate because you need the calories, or you're going to use a lot more healthy oils on your foods for flavor and for calories. So look at what your goal is for you at that point in time. I think that's really important. The last kind of food group that has not been mentioned is the dairy group, and I put or plant-based alternatives. Many health-oriented nutrition programs throw dairy out the window. There's no true connection between dairy and cancer risk. There are some studies that show in advanced prostate cancer, we do need to be careful about how much calcium you're taking in. So if you're eating a lot of calcium-rich foods and taking calcium supplements, that might be a problem. The real connection between dairy and cancer often is related to the higher fat dairy products, which cause people to eat a lot more calories and change their body mass index, or obesity and adipose tissue. So that dairy is your choice. Again, most of us don't. There's a few of us that need to gain weight, and there may be times when even I've talked to people in treatment where I'm saying, yes, buy whole milk, buy whole yogurt, because you want every swallow to be as powerful as you can for calories. But as you don't need to be looking at maintaining your weight or gaining weight, that's when you start scaling back and looking at using non-fat dairy products. Or if you do choose to use a plant-based alternative, to look for those that are fortified with calcium and vitamin D, and most of them are, but they're very different in their protein content. Which brings me to my favorite topic of protein. As we age, we need more protein to help keep our muscles strong, as well as using them with exercise. So a plant-based alternative that has protein might be something that really would add to your total day's intake of protein. So we've talked about kind of what is a plant-based diet, and no matter where you are on that spectrum between like a vegan or just beginning to think about, wow, I maybe should add a vegetable to my day, to why are you doing it, and is your goal to just be healthier? Are you doing it just because other people say you should do it? You need to really own why you're doing it. But then, and we talked about kind of how you do it, but okay, I've identified a few meals in my typical what I eat that are plant-based. What do I do from there? And that's where we want to maybe start collecting some recipes, stock your pantry, and batch cook. So this is your pantry. One thing I've talked about, maybe adding a new grain to your pantry, but a lot of the whole grains and beans take a lot of time to cook. So it's totally fine. It's not unhealthy to use a packaged processed food such as canned beans. Again, mostly what's in these products is just the bean itself. You can buy those that are unsalted, or you can buy organic or not organic. So, eating whole foods doesn't mean you never use a convenience food. And going back on the batch cooking, when you do cook grains, cook more than what you need, because you can have one, you might have it as a side dish. The next day you throw it into a bowl. And when I talk about a bowl, it might be lining a bowl with some greens. You throw in a grain, you add some legumes like, black beans, and you might add some extra cut up vegetables. You put a flavorful sauce on it, or you may use the grain in, a wrap with, again, more vegetables, more of a sandwich. So, you don't have to cook it all the time. I mean, I hate washing my dishes. I hate spending 40 minutes to cook something. So these grains are well kept in the refrigerator. You can buy pre-cooked brown rice that's frozen in places like Trader Joe's. So it doesn't have to be a time-consuming process. I put this up here because some of my favorite go-tos for plant-based eating is Cookie and Kate. Cookie's the name of her dog. These websites have a lot of recipes online, but they also offer cookbooks. The Cookie and Kate one, I have purchased her cookbook. It's about $15 and given it to family members. I will say there's not one thing I have cooked out of there that was not excellent, and they're easy to do. The Dish Knowledge is a dietitian, and so this is great for a home that has maybe some school-age children, because it's how do you present some of these foods, in a fun way, because a lot of our eating habits are established from our growing up years. Not that they can't be changed, but there's just, it's great reference. Sharon Palmer, RD, is a completely vegetarian dietitian. She maintains all her social media websites, but she has a lot of great resources, like how do you have a pantry, or she might do a weekly meal, weekly plan. I mean, a lot of the basics on how to do it. AICR is the American Institute for Cancer Research. I would recommend this website highly to people for evaluating their exercise, for looking at their diet. You can put in the search bar like flaxseed, and then it'll tell you all the phytonutrients that are in flaxseed and how you might use it and why you might want to use it. So any questions, that's just a very user-friendly website. And the Pinterest I put in there because, okay, I went to the market, I tried a new vegetable, and now what do I do with it? So you can put in the search bar whatever the name of that vegetable is, and it'll come up with lots of ideas. And again, some of them might be less fat or less this than others, but it gives you an idea that, yeah, wow, I never thought about that. And so that's really kind of fun to do. So is plant-based eating complicated, or can it be simple? And again, maybe for you, it's taking one meal of the day. Oh, and maybe breakfast is the best way to start it. Think about, what do you normally have for breakfast? And how can you add some produce into it? Or how can you make sure there's some whole grains in it? Work at one meal at a time. And just go with that. Start simply, one step at a time. Then you decided, I'm going to do this simply. And then you go to the market and you see all these labels and you're like, I'm back in that mindset again. What do I do? There's too much. This is confusing. This is overwhelming. Am I supposed to do it all? And I just want to say, don't overthink it. Okay? You get so much in your mind that you forgot about the fun part of food. You forgot that food is an ally for you. Food is something that we socialize with, that sustains us, that we want it to be yummy. We don't want it to take a lot of time. So, I also like to use an analogy when you see a remodeling in your neighborhood and they've torn the house completely down. It takes a long time for them to build that foundation of the house before they ever start putting up the framing. So what we want to do is look at, what is our foundation of our diet? We're not going to think about, oh, is it all organic up here? You hang your pictures up in your house last. let's get the foundation down here. Are we eating a balanced diet, a variety of foods? Let's try to eat some more vegetables. It doesn't matter if they're organic or not organic, if they're GMO free or not GMO. Or grains don't have to be gluten free. They don't have to be this. They don't have to be that. If we don't eat them, they're not going to help us. So don't overthink it. So end of this is put more plants on your plate. It doesn't have to be impossible. Ask yourself, how can I add a vegetable or fruit to this meal? And end with dessert. I love this picture, so I had to put it in there. And again, it doesn't mean you never eat a dessert item, but you're not going to be eating dessert for, your neighbor's birthday, your cousin's birthday, then, at the workplace, at this. And I also like to say, when you have something that you really enjoy, it's not off the board completely. It's how often are you eating it? How big of a portion are you eating it? Are you enjoying it while you're eating it? Or are you feeling so guilty about eating it that you're like shoving it down? So, it's much different to take a spoonful of the ice cream you really want and put it in your mouth and let the flavors expand than, picking up a cookie that you really didn't care to have. So yes, include dessert, but again, it's the foundation that we want to have as to support ourselves, to help prevent disease, to help manage our weight, to enjoy food. Look at it as an opportunity to explore the different foods and eating. So that ends my that, and I will open it to questions. And it looks like there's quite a few, maybe. Is there any food or drink, including alcohol, that no one should give up for life during and after treatment, even when in remission? And I think I did mention that at the very end, that as soon as you blacklist a food or a drink, then that's exactly what you want. Alcohol occasionally, they say, okay, red wine's good for heart health. And at the same time, breast cancer patients, they're saying, it would actually be best if you hardly ever had it. So moderation is a key. You might want to discuss that directly with your physician. Sometimes it interacts with medications that you are taking. But overall, there's not any one food or drink that you should give up for life. Another question. Mouth sores were by far the most debilitating part of my first 2 recessions. Helios, she took it faithfully, never had a single episode of mouth sores again. Thank you for that. I have seen that work for people too. So if you are still in treatment with some agent that can cause mouth sores, talk to someone at the cancer center and they can introduce you to a product that might help with that. Are the plant-based slides available online or can they be emailed? On the next Cancer Connection newsletter, I do have a plant-based eating article which has some of the links to things. It kind of gives a summary of the presentation today. And if you had a specific question, I probably wouldn't email all my slides, but I can also do a follow-up article. And if you're not part of the Cancer Connections newsletter, then we can get you on that. It's a monthly newsletter. Are plant-based beef burgers really good for you? I have never tried a plant-based, well, I've tried a couple of plant-based burgers that are already made from like frozen that you buy. But what I have a tendency to look at all the ingredients and say, I'm not sure if I want to do that. There are a lot of recipes where you can do your own. And so, I think that's a personal choice. Sometimes if you want the convenience of it, I think that's fine. Again, no food's off the table. Another question, what supplements, if any, are helpful? That's a great question. For part of cancer survivorship, I strongly recommend that you know what your vitamin D level is. Cancer survivors should have an adequate vitamin D level, so that should be part of an annual lab value, lab draw. It's not automatic at the cancer center. It might be with your primary physician. Many people are deficient in vitamin D and do need to take a vitamin D supplement, maybe lower maybe a higher level if they're deficient. And then even when they get to a normal level, they may need to take 1,000 to keep their vitamin D level up. Beyond that, the only time you would need supplements is if you are a cancer patient who has had part of their gastrointestinal tract removed because of that cancerous tumor, then you may not be absorbing some of your nutrients like you would have if you had your gastrointestinal tract intact. So that's a very individualized thing, and that is something to talk with your medical oncologist about, or myself about, because definitely if you've had any like stomach cancer or esophageal cancer, or have had some of your intestine removed, you may need, or if you have a pancreatic cancer, then you may not be absorbing some of your nutrients. All right, I'll just keep going. How can I apply these principles when I'm lactose intolerant, glucose intolerant, and on limited fat consumption with gallbladder removed? Lactose intolerant to plant-based diet works great. And again, that's when the plant-based dairy alternatives would work for you. There are a lot of whole grains that are gluten-free. And, we don't recommend a ton of fat anyway. So I see that this would go perfectly for following all those diet modifications. During chemo and radiation, again, we want to relax kind of these gold standards of plant-based eating, because my 3 nutrition goals for people when they're going through active treatment are that they eat enough to prevent unplanned weight loss. And I put that unplanned weight loss in there because if you are eating healthier, you may be losing weight. And if you started at a higher weight, that's okay. We just don't want to see you taking deep dives with your weight, or on the other hand, all of a sudden gain a bunch of weight. That's not healthy either. The second goal is making sure you get enough protein. And the third goal is drinking enough fluids. So that kind of is more important than all the fine tuning of a plant-based diet. Is any one plant-based diet better for diabetics? You can do any of that spectrum from vegan to Mediterranean. For a diabetic, you are really looking at, again, complex carbohydrates, all your non-starchy vegetables do not influence your blood sugar as much as other things. You're eating whole fruits instead of fruit juices, regular scheduled meals. It all works perfectly for a diabetic. What is your general philosophy about telling the truth about your cancer or your cancer situation? I sense a reluctance to be forthcoming. I'm not sure what that means, telling the truth about your cancer or pre-cancer situation. I might not be able to answer that. I'm not sure what that question is actually asking. So I apologize for that. The next question is a great one. If I'm prone to diverticulitis, do I avoid raw and try to cook most things? With diverticulitis, that's an inflammation of your intestinal tract. And if you have like a bout of actual inflammation, then that's probably when you want to do a little less whole grains and do cook your vegetables. But to prevent diverticulitis and to keep your intestinal walls strong, you actually want a lot of fiber. So, you do want a high fiber diet, which will come from plant foods. Plants are the only foods that have fiber, and fiber is what you can't digest, and it actually moves through your intestinal tract. So for diverticulosis, you want a high fiber. If you're having a flare up, then you may need to, kind of chill out with the fiber and go for the lower fiber grains, which are your refined. That's when and this would be true if you were having diarrhea with chemo. That's when you scale back and you do the white pasta, the sourdough bread, the white rice, tender cooked vegetables, soft fruits, or peeling your fruits. So that would be the same with diverticulitis. Plant-based eating, thinking about I like this question because I think a lot of people have the same mindset, thinking about doing a plant-based diet for years, but it never happened on a transition basis. It only worked when we went cold turkey. It forced us to get in with it. And nearly 3 years later, it's been transformational and becoming healthier. and it's reduced prescription medicine for blood pressure and statins. So I think it's really important to understand who you are. Sometimes it is like, I'm changing things. I got to go empty out my pantry. I'm not bringing these things into the house anymore. And some people, it's overwhelming and they might feel successful with smaller steps. So that's something that we can identify more if I was working with you, I try to identify, what strategy would work for you. And I also like to say, don't feel guilty if you all of a sudden try to go this way and it didn't work one day. Just like get back on the bike, get back on the horse and try it again. So I appreciate that comment. And we have had some great success stories. We have some other departments at El Camino Hospital, like our cardiac rehab, which does a plant-based eating. We have the South Asian Heart Center, which does plant-based eating for diabetes and heart disease. And in those types of diseases, like heart disease, often you can totally reverse your clogged arteries with plant-based eating, which brings me to a great statement, is that for nutrition in cancer, nutrition supports you through treatment by keeping you fueled and strong. It is a complementary thing to your cancer treatment. It should not be an alternative. It's very sad when you meet someone who has tried to cure their cancer through food alone and put off medical attention, and then their cancer has advanced. So all the good things about nutrition cannot cure cancer. It can keep you healthier. It can reduce inflammation. It can be part of cancer survivorship as far as, just being healthier. So you cure yourself from cancer, you don't get another chronic disease. Also, when you start eating healthier, perhaps you're not gaining weight as you age, because when you gain weight, or if you are overweight and you're done with cancer treatment, that is a time to implement exercise and to try to lose a little bit of weight, because it's like your metabolic profile, that whole ABC soup behind the scenes kind of gets skewed, and we can kind of correct that when your body weight improves. So that's key. And along those lines, the other thing that I've talked about in the past when I did a discussion on fasting is like a 13-hour fast at night. It doesn't have to be longer than that. Kind of can reset your metabolic profile. So I think I might have answered all those questions.
Thank you, Charis.
Yeah.
This is Brian with El Camino Audio Visual. We're going to conclude our program. On behalf of the Cancer Center, we would like to thank all our guests for joining us this morning. Please enjoy the rest of your weekend and remember to exercise and eat your vegetables. Good day, everyone.